Hello, everybody, and welcome back to another talk in our Technologies in TBI mini-series. Again, I'm Dr. Matthew Shem. I work here at the Functional Neurology Center in Minnetonka, Minnesota. And what I'm going to be talking about today is the autonomic nervous system. So we're going to break down what exactly the autonomic nervous system does, what are the functions it's kind of responsible for, what happens whenever it's not working right, what are different symptoms that you could experience whenever things aren't working right, and then we're going to go into the assessment and treatment. So we'll go over different assessment strategies that we use here in the office, and then different treatment strategies that we also use here in the office in order to best serve you. So the first slide we have here is we have to discuss first off, what is the autonomic nervous system? So first off, the autonomic nervous system is pretty much all about things that are automatic. Automatic. This is a part of your central nervous system that controls the processes we don't have to think about. So it's automatic, it's non-volitional, such as breathing. I'm not thinking about breathing right now, but hopefully I am. Digestion, pupil reactions, blood pressure, heart rate, and perspiration. These are all things that happen automatically without me having to think about it, which is good because I now have the ability to do other things that I want to do versus if I had to think about all these things every day and every single minute of every single day, then it would become a difficult world to live in, you know? So in the autonomic nervous system, we have these two different divisions. We have the sympathetic division, and that's basically what they call the fight or flight division, where it kind of ramps everything up. And then we have the parasympathetic division, which is the rest and digest section that kind of slows everything down. So it's important to be able to assess the autonomic nervous system, and dysautonomia is pretty much the catch-all term of all the different symptoms that you could experience whenever there's problems with your autonomic nervous system. So things that you might experience are things like dizziness, lightheadedness, fainting, migraines, headaches, abnormal sweating, fluctuations in heart rate, and all these different things. And so it's important for us as providers to be able to look at you as an individual, as a single person, and not compare you against other people and try and get to the root cause of what's causing your issue. So we have to rule out all things structural, all things neurologic, and then all things metabolic. So if we talk about neurologic, which is basically our wheelhouse, we'll do a comprehensive bedside examination where we can look at things like we'll do your blood pressure and your heart rate when what it looks like whenever you're laying down versus seated versus standing up, see if it spikes or drops whenever you go through any of those different maneuvers, and then compare it against whenever I actively do all that versus if I'm laying on a tilt table and I'm just laying there and it passively elevates me. So it's important to be able to assess these different things because there are two different mechanisms behind that. If I stand up actively, I now have to what we call feed forward and feed back. Whereas if if I want to stand up on purpose, I now have to create a plan to tell my muscles and my legs specifically, okay, you have to contract so that I can stand up. If I want to use my arms to like help me up, I have to be able to do that. And then more importantly, and especially something that ties into people getting dizzy with these orthostatic changes is blood flow. Blood flow is very important because we don't have enough blood in our body to be able to be everywhere at the same time. So it's important to be able to shunt the blood to the appropriate places at the appropriate time. For example, if I'm standing up, I need to be able to shunt blood to my legs to be able to contract the muscles that would be required to make me stand up. But I don't want to shunt it all down there because if I shunt it all down there and I don't shunt any to my head, then I'm going to get lightheaded. I'm going to go hypoxic and pass out. And we don't want that, right? So it's a fine tuning system of sending blood to the appropriate places. And a lot of times after concussion, this mechanism can get messed up where if, if to tie back into feed back and feed forward, if I want to stand up, my brain has to create a plan and tell my legs and tell the muscles in my legs, you have to do this. And we're going to shunt blood here and we're going to move here and all these different things. So it creates a plan. And then while I'm doing that activity, and even after I'm doing that activity, you have feedback from the muscles and from from the body saying, this is what actually happened. And whenever both of those plans come together and they say the same thing, that's when we're in harmony, and that's when the brain is happy and everybody's happy. And that's whenever we don't experience any symptoms. But what happens a lot of time with concussion is the initial plan that the brain creates to say, I want to achieve this goal, doesn't match the feedback or the intended feed or the feedback that comes back from the body. And so the intended action and the feedback of what actually happened doesn't match. And that's what we call a sensory mismatch. And that's where things can go awry. And that's where the cerebellum comes into place, and coordinating these different activities so we can assess that. And then if there's problems there, we can jump into this route of treatment. And if there's problems in a different area, we can jump into this route of treatment. And it's all about being able to provide the appropriate care. So then from there, we can progress to the tilt table testing. And we talked about this a little bit on the first day, but I think it's really important in this talk. So we'll dive into it again, where if I'm laying on my back and I'm say I'm, as the physician, doing your blood pressure or your heart rate and looking to see if it's drops or spikes or anything like that. If I'm elevating you on a table without you actually having to move, it's now a passive motion. And it's now all about, how does my brain integrate gravity? How does my vessels respond to different gravitational changes and things like that? So obviously we're detecting, how does my brain respond to different gravitational forces as I'm changing my position relative to Earth vertical. And then also we have what's called baroreceptors in our carotid sinus and in the aortic arch off of the heart. Because if I stand up and my blood pressure skyrockets, then it's going to cause a lot of pressure in my arteries, and it's going to stretch out the walls of the arteries. And that's what we have these baroreceptors for, which they're basically stretch receptors. Whereas if these receptors or the walls of your arteries get stretched a little too much, then that signal fires into the brainstem, into the NTS or nucleus tractus solitarius. That then fires back down to the heart to say, hey man, if you don't stop pumping so hard, we're going to blow an artery. And so it's like this feedback loop that we have here. And then on the flip side of that, if I stand up and my heart rate tanks, and now my arteries aren't having any pressure against them, then there's not enough stretch on the receptors. And that signal again goes into the brainstem and back down to the heart to say, hey, if we don't pick up the pace a little bit, then I'm going to pass out. I'm going to drop. I'm going to start to feel faint. And so it's this constant regulation of what's the appropriate thing to do at the appropriate time. So it's why we have to do all these different tests in order to classify you in the most appropriate diagnosis to then supply the most appropriate care. So then going on from there, we can do something like a detailed eye movement assessment with the VNG, like we talked about in the first day, with diagnostic technology, and what we'll dive into a little bit more, I believe, tomorrow when I talk about oculomotor function. And basically, I'll keep it really short in this talk because we kind of talk about it a lot. I know in my talks, and I'm assuming a number of the other speakers will be talking about it as well, where we can look at, how do your eye movements look in the horizontal plane? How do they look in the vertical plane? How do your smooth eye movements look versus your quick eye movements? How fast are they? How accurate are they? How long does it take you to initiate looking at it? What does the eye position of your eye look like? All these different things are so important to assess when it comes to neurologic function, and specifically concussion for sure. Because like I've said a number of times already over the course of my talks, has been that the machinery in the brain is so vast and that is responsible for eye movements, that we can look at all these little things and be able to localize to a more specific degree where the problem is in your brain, so then we can apply the appropriate rehab and get you better in the quickest manner possible. And then from there, what we go on to is balance testing. So we can use the B tracks, which we talked about in the first session, or computerized posturography. We basically have you stand on this platform, and we'll take you through different tests where you stand with eyes open, eyes closed. Then we put a foam surface on there, have you test eyes open, eyes closed, and we'll just compare, how does your vestibular system look? How does your proprioceptive system look? How does your visual system look? And we can see which one's working too hard, which one's working not enough, and then be able to then again be able to apply the appropriate rehab. And it's all a fine game with patient care, really, where you can't classify every single patient into the category that you see. So we have to be able to look at all things. And that's why it's important to be able to listen to the heart, be able to do the different neurologic functions, and then also see if we're missing any underlying metabolic factors. So we'll do different lab work and see, hey, do you have anemia? Hey, do you have mold infection? Hey, do you have anything else? You have inflammation, things like that, that could all cause these symptoms and could be better suited by doing supplementation or dietary changes versus doing the rehab. Um, so I hear it all the time when with patients that I've seen over the last few weeks specifically and over the last few months, is that they say they come in with this 3 or 5 inch binder, even with all the different providers that they've seen, and they go see them after a concussion, and whatever provider it is, they're basically told a lot of times that this is probably going to be your new normal. And people don't want to hear that. As I'm sure if you deal with any of these symptoms, you don't want to hear it either. You want to know that there is a cure and that I can get back to the normal that I used to have. So here at the Functional Neurology Center, we utilize a myriad of different therapeutic applications to be able to best suit you. And so some of the different things that we could use in order to help dysautonomia in particular are things like neurological and physical exercises. Physical exercise is important because especially in today's sedentary lifestyle, people just become really deconditioned, and they have to be able to get blood moving. And it's important with dysautonomia in particular, because a lot of times people are sedentary, and the way that our arteries and our veins work is arteries have contractile muscles in them that actually pump the blood out and keep it going out of the heart. But veins don't have that, where veins don't have a pump to get the blood back to the heart, so it can pool in areas like your legs. And when blood pools, you don't have enough blood to then use for other things. So things that we can do is like loading the legs with weights and doing different lower body exercises and things like that, where the only way to get blood back to the heart from the legs is through skeletal muscle contraction, because the muscles, or the muscles of my legs, or the muscles of my arms, or all these bigger muscles that we actually see, they contract and they squeeze the veins, and basically like squeezing toothpaste out of a tube, they squeeze the blood back up to the heart so it's back into the pump and it can get recirculated. So it's important to be able to do obviously neurologic exercises, but obviously physical exercises as well for things like this. And then another thing that we use here in the office is low level laser, and that's something that I will be talking about tomorrow, I believe, or maybe the next day. So I'm not going to brush on it too much here, but we'll go into it more in depth there. And then again, with tilt table, we use it obviously diagnostic, how we talked about earlier, and we also can use it therapeutically, where we can basically find the vector of gravity that you have difficulty interpreting. Or let's say that whenever I get to 37 degrees, my heart rate tanks or my heart rate spikes. And so what we can do is we can take you below that and oscillate you back and forth and have you integrate that position or that vector of gravity a little bit better. Or we can stop you there and do different activities. Like, for example, this is the SSEP, or non-invasive cranial nerve stimulator, right here in this picture. SSEP stands for somatosensory evoked potential, and basically all it does is activate the different nerves, and we can use it on the face and activate different regions in the brainstem, or we can use different nerves in the body and just send feedback from the body and different things like that. But specifically, whenever we're talking about dysautonomia, is you can activate back into the brainstem the regions that are really close to the areas that regulate your ability to um, shunt blood to the appropriate places and regulate your heart rate and things like that. So that's the idea behind using something like this, which is just a basic electric stem that can fire back into the brainstem and make those areas a little bit healthier so that they can do their job more appropriate. And then obviously, like we said, let's say that we come in or you come in and you have these dysautonomia like symptoms and all of your neuro exam looks good, your heart sounds good, your tilt table testing looks good, your eye movements look really good, your posturography looks really good. And then we do your labs and we find that you have an anemia, an infection, and inflammation, all these other things. So then we go down the route of, okay, well, I think you look pretty good neurologically overall. So let's go down the nutritional and lifestyle coaching route that would better suit you versus trying to cram you into a model that doesn't fit your case. So that's all I got for you today. I hope you were able to learn something, and I hope that you were able to gain something out of this talk. If you have any questions, please feel free to just drop them below, and either myself or one of the other doctors will get to them as soon as we can. Other than that, I hope you have a great day, and I look forward to getting on here and doing the next one. So talk to you soon.